Fetal Alcohol Spectrum Disorders, FASD, an introduction, created by the Green Mountain FASD Project, presented by Rebecca Eileen Mintz and Kelly Guile.
Fetal alcohol spectrum disorder, or FASD, is a term used to describe a range of effects that can occur in individuals who were prenatally exposed to alcohol. Everyone is affected by prenatal alcohol exposure differently, which is why there is no known safe amount of alcohol to consume during pregnancy. The effects of prenatal alcohol exposure can include a combination of physical, mental, emotional, and/or behavioral problems.
FASD is known as an umbrella term rather than a single clinical diagnostic category. There are several different types of FASD: fetal alcohol syndrome, FAS, neurobehavioral disorder associated with prenatal alcohol exposure, NDPAE, alcohol-related birth defects, ARBD, alcohol-related neurodevelopmental disorder, ARND, fetal alcohol effects, FAE, and partial fetal alcohol syndrome, PFAS.
Here are some quick facts about fetal alcohol syndrome to keep in mind as we go through the presentation. FASD is 100% preventable by not drinking while pregnant. There is no known safe amount of alcohol to drink during pregnancy. All types of alcohol, including beer, wine, and liquor, are equally harmful. Alcohol is more harmful to a developing fetus than cigarettes, heroin, crack, or cocaine. Alcohol can harm a fetus at any time during pregnancy, even before a woman knows she is pregnant. FASD is the leading preventable cause of intellectual disability and birth defects.
FAS is the severe end of the FASD spectrum. FAS is characterized by distinctive facial features, growth deficiencies, and central nervous system damage. People with FAS might have problems with a combination of the following: learning, memory, attention span, motor function, communication, social skills, vision, and hearing.
ARND and NDPAE are terms used to describe a complex range of disabilities in the brain development, social behaviors, adaptive skills, and self-regulation. Characteristics of both disorders can include memory and visual spatial impairments, poor impulse control, mood disorders, delayed language, poor social skills, and difficulty managing daily life. Individuals with ARND or NDPAE were prenatally exposed to alcohol but do not display the distinctive facial features of FAS and may or may not present with growth deficiencies and structural central nervous system abnormalities. NDPAE is a new diagnostic classification, but not an official mental disorder diagnosis.
ARBD describes the physical defects in the skeletal and organ systems that are associated with prenatal alcohol exposure. These defects can include malformations in the heart, skeleton, kidney, ear, and eye.
The Center for Disease Control and Prevention, or CDC, estimates FASD to be at 1 in 100 live births per year, which is roughly 40,000 infants. However, a recently published study by Dr. Philip May in the journal Pediatrics estimates the prevalence of FASD in children to be a little higher, between 2.4% and 4.8%. According to the CDC and the Substance Abuse and Mental Health Services Administration, FAS, the most severe form of FASD, is found in 0.5 to 2 per 1,000 births. The lifetime cost of FAS for one individual is around $2 million in services and support. Annually, FASD costs the United States around $4 billion. This chart, created by the Texas Office for the Prevention of Developmental Disabilities, shows how the prevalence of FASD is much greater in births per year than other developmental disabilities. Although FASD has a higher incidence, Many of these disabilities, like Down syndrome and spina bifida, garner much more public awareness and attention.
The 2012 CDC National Vital Statistics Report determined that there were 6,009 live births in Vermont in 2012. Based on the national estimates of FASD and FAS prevalence, this puts the number of children born in Vermont each year with FASD around 60 and children born with FAS between 3 and 12.
According to the Substance Abuse and Mental Health Services Administration FASD Center for Excellence, 1 in 2 women reports any alcohol use in the past month. 1 in 4 women reports binge drinking in the last month, and 1 in 20 women reports heavy alcohol use. Binge drinking is defined as 5 or more drinks on any one occasion. Heavy alcohol use is defined as binge drinking on at least 5 days in the last month. Standard drink sizes are as follows: 12 fluid ounces of regular beer, 8 to 9 fluid ounces of malt liquor, 5 fluid ounces of wine, and 1.5 fluid ounces of any 80 proof liquor, which includes vodka, rum, whiskey, and gin.
According to the Substance Abuse and Mental Health Services Administration FASD Center for Excellence, 1 in 5 pregnant women reported alcohol use in the first trimester, 1 in 14 reported alcohol use in the second trimester, and 1 in 20 reported alcohol use in the third trimester. Additionally, 1 in 30 pregnant women drink at levels shown to increase the risk of FASD.
The Behavioral Risk Factor Surveillance System, or BRFSS survey for 2012 estimated the amount of binge drinking in females aged 18 to 44 years old. The dark blue states have the highest amount of binge drinking.
Based on the CDC BRFSS for 2012, Vermont is ranked second highest in the nation for any alcohol use and 7th highest for binge drinking. 65.8% of Vermont women between the ages of 18 and 44 reported alcohol use, and 23.7% reported binge drinking in the last 30 days. Since Vermont has such high rates of alcohol use, it may indicate that Vermont has a higher unreported incidence of FASD than other states.
Diagnosing FAS can be extremely difficult as there is no single test to diagnose the disorder, and many other disorders like ADHD have similar symptoms. This often leads to misdiagnosis, delayed diagnosis, and unreported cases of FAS and FASD. FAS is the only form of FASD with a medical diagnosis. Diagnosing is usually done using the 4-digit code developed in 1997 by the Washington State FAS Diagnosis and Prevention Network at the University of Washington.
When diagnosing FAS, all 3 of the following traits must be present: abnormal facial features, growth deficits, and central nervous system abnormalities. The abnormal facial features include a smooth pallithrum, the space between the upper lip and the nose, a thin upper lip, and wide-spaced eyes with small eye openings. The growth deficits associated with FAS mean that the height and/or weight of the child is at or below the 10th percentile. Finally, the central nervous system abnormalities can include traits such as low IQ, poor organization, attention problems, balance problems, and impaired social skills. Additionally, confirmed alcohol use during pregnancy can strengthen a diagnosis, but is not necessary to make a complete diagnosis.
The 4-digit diagnostic code was developed by the Washington State FAS Diagnostic and Prevention Network, or FASD-PN, in 1997. It is intended to be used by an interdisciplinary FAS team when diagnosing an individual. The 4 digits represent the expression of the 4 key features of FASD in the following order: growth deficiency, FAS facial features, central nervous system abnormalities, and prenatal alcohol exposure. The magnitude of expression of each feature is ranked independently on a 4-point Likert scale, 1 equaling complete absence of the feature, and 4 equaling strong classic presence of the feature.
FASD is a major unmet public health concern. It affects many individuals who will then require specific services for the rest of their lives that are not always available. Many individuals have concurrent mental health disorders as well. SAMHSA has found alarming statistics with those who have an FASD and a co-occurring disorder or issue. These include, but are not limited to, co-occurring mental illness, issues with independent living, disruptions in school and with employment, and inappropriate sexual behavior. According to the National Organization on Fetal Alcohol Syndrome, or NOFAS, over 60% of individuals with FASD over the age of 12 have been charged with a crime, and 55% of people with alcohol-related birth defects will be confined to a prison, psychiatric institution, or drug and alcohol treatment center. FASD is a very important issue to discuss because many pregnant women receive mixed messages about alcohol and pregnancy, like it's okay to have wine, drinking in the last trimester is fine, drinking in the first trimester is fine, or don't drink at all. However, only 1 in 6 adults actually talk with a health provider about their drinking, so they are getting this information from other places rather than a healthcare provider. It is important to raise public awareness about FASD because it is 100% preventable by not drinking during pregnancy.
We are part of the Center on Disability and Community Inclusion at the University of Vermont. The goals of the Green Mountain FASD project are to promote FASD awareness and prevention in Vermont, while also providing resources, education, and training to the community. You can view our website at www.uvm.edu/cdci/FASD.
These other state initiatives and national resources provide FASD education, training, diagnosis, and support for families, friends, and healthcare providers involved with FASD care. The National Organization on Fetal Alcohol Syndrome, the Minnesota Organization on Fetal Alcohol Syndrome, Not a Single Drop, Florida Fights FASD, the Center for Disease Control and Prevention, the Substance Abuse and Mental Health Services Administration FASD Center for Excellence, and the ARC.
Questions or more information, please feel free to contact us.